My name is Jeremy Dearling. I come from Kingsley, Norfolk. I am part of the Cambridge Experimental Cancer Medicine Centre patient group.
I'm Maria Crispin. I'm a group leader here at the Early Cancer Institute. I run a computational lab that focuses on machine learning for image analysis. And we also do a lot of data integration to understand why patients respond to treatments or why they don't.
I'm fascinated. Please explain to me, what is artificial intelligence?
Artificial intelligence is a computational system that is able to do things that traditionally only a human would have been able to do. Because from a cognitive point of view, it requires a type of thinking that in the past we thought that only humans would be capable of doing. That means making decisions, it means identifying patterns that are really subtle, it means having to mine huge amounts of data. It's those types of tasks that can be done by an artificial intelligence system.
What do we mean by the use of artificial intelligence in cancer research and patient care? And what do we not mean?
It's not a robot, it's not something particularly scary. It's a type of program like many others that we use routinely in the medical setting. It just means that it's seen more data, it's more powerful, and it can learn from experience, which other devices, other computational programs that we have, let's say, fine-tuned, that we have designed following a set of rules wouldn't be able to do because they've been predetermined to do something. Whereas with an artificial intelligence framework, we can give it data, we can show it that experience, and it will be able to make decisions based on what it's seen.
What does artificial intelligence actually look like?
What does it look like? Most of the time, AI is literally just like any other program a doctor will have in their computer. So it doesn't look special in any way. They don't talk to you. They don't have a face. It literally is just a program that's running in the background.
Hi, my name's Lynn Cundy-Jones, and I'm a patient here at Addenbrooke's. So how can AI be used to support personalised and targeted cancer regimes?
What's really special about artificial intelligence is that these models can take in a huge amount of data and extract patterns and learn how to make decisions by taking in the uniqueness of every single case that we show to the model. And this, for diseases like cancer, is extremely important.
So what impact will the use of AI have on the flow of clinical practice, and who prioritises which research is a focus?
There are many ways in which AI can support clinicians and generally clinical care. There's been a lot of work around how AI should be implemented in the clinical setting. And universally, when you ask patients, there's a common message that is that AI should always be supporting the role of the clinician and never really replacing them. It just means that their tasks and what they focus their attention on is going to change. And so the idea really behind this is that we can get the artificial intelligence models to do the simple stuff.
My name's Grant Stewart. I'm Professor of Surgical Oncology or Cancer Surgery at the University of Cambridge. I'm also a consultant urologist treating people with kidney cancer at Addenbrooke's Hospital.
Will AI replace researchers and clinicians?
I don't think it will. I think it will allow us as academics, as doctors, as researchers to be more effective and to stop doing the tasks that are more mundane, that are pattern recognition, that can be automated.
Will AI replace research and clinical trials?
I don't think AI will replace research and clinical trials, but again, it will probably mean we do things differently. So, for example, there are huge amounts of data on clinical trials across a range of different diseases. Can we undertake simulated clinical trials with new agents using a lot of the previous knowledge that we have?
I'm Dr. Frankie Williams, and I'm a member of the patient involvement group for the new cancer hospital in Cambridge, and I'm on various groups within that. Where are the potentials for AI to make a significant contribution to cancer care? within the next 5 or 10 years?
An area that I'm really interested about, and obviously I'm biased, is the early cancer setting. These models are capable of integrating many different types of information and also to create these patient journeys in a way that we have not been able to do before. Something we're doing here in Cambridge, for example, is parsing histories of the patients in our studies and creating these automated patient journeys by looking at all of their clinical reports, all of the pathology reports, all of the radiology reports, and understanding what happened that led them to eventually develop a cancer. And in the future, if we can catch those cancers early, that's going to massively change basically the outcomes and the future for those patients.
How accurate is AI?
You can't really talk about AI as a single general thing. Every AI model is different. It solves a different task, and it will have been trained on a different data set and evaluated in a different cohort. So it's hard to talk about performance in general. If you want an AI model to be deployed clinically, it needs to satisfy certain criteria that are set by the medical device regulators. And so if you don't hit the necessary performance that is considered to be valid from a medical point of view, that AI method will just not be usable as a medical device in the clinic.
What safeguards are in place to prevent AI making errors in diagnosis or treatment recommendations? Who will be held responsible?
Ultimately, as medical practitioners, we are responsible for the care of our patients, and therefore the decision making lies with us, and any consequences of incorrect decision making lie with us. And there needs to be a duty of candor with patients about why certain recommendations are made, and then if anything goes wrong, with what's gone wrong. So it is down to the doctor. For a tool to be used in clinical practice, it needs to be validated. So it's all well and good coming up with an interesting proposition in the research setting, but then that approach needs to be taken forward into a fresh set of people with being treated in the normal way, and for that approach to be used with them. So be that around making treatment decisions, around the results of imaging or pathology results, that all needs to be checked in a separate group of people, ideally in a different location from the place where the original work was undertaken, so that we can be as sure as possible that our model is correct. And equally understand the tolerance of that model, the accuracy of that model, so that that can be reported in an honest way to patients, and give them a likelihood of an incorrect decision being made.
How expensive is AI?
Developing these models can be expensive. Particularly the most powerful ones require a lot of computational power, and that's not to be underestimated. Obviously, the AI models have to learn from something. You need to create those data sets. And we're talking basically about clinical studies and data from patients that not only needs to be obtained and acquired, but then also needs to be curated and stored, et cetera, et cetera. So that's a significant cost. The great thing about an AI model, once it's been trained and it's learned to do something, is that deploying it is actually very cheap. And one of the really exciting applications of AI is saying, well, if you don't have immediate access to a specialist somewhere, could you use one of these models to get an initial idea of what's going on, or to help you make a decision about how to go forward? And that's, I think, a really promising application of these models.
So as a global project, how will information be shared internationally amongst clinicians, and what safeguards will be put in place?
There are very strong data protection guidelines globally for medical data. Certainly for sensitive data, for anything that could potentially identify a patient. We would never do research on identifiable data, for example, full stop. Once it's been anonymized, there are very clear protections around where that data can even be stored, certainly by whom it could be accessed. So there's GDPR that we're all familiar with. It also applies to medical devices. The US also has their own regulation, but they all have very, very high standards. In terms of how we share, there's several routes. You can do bilateral agreements. You can decide to share data, and this means that the legal teams from the institutions get together and discuss exactly how all of these things are going to be addressed. And when they're confident that the level of protection for the data is going to be adequate for their local regulation, and an agreement is signed. And usually these agreements have an end date.
Who regulates and monitors equality to ensure it's built into collected data?
That's a really good question. And when we create models, we always try to create data sets for training that are as representative as possible. But it's almost impossible to really include everyone. To me, probably the single most important step when you develop one of these AI models is the validation. And particularly, as you say, a relevant validation exercise. And by relevant, I mean, well, where am I going to be using this model? Let's establish cohorts. Let's get, partnerships, create partnerships with the right institutions that can give us access to those groups and test our model and see if it really works. That, to me, has to be done as part of the initial development of the model. But in any case, once it's a medical device, as part of the usual medical device regulation requirements, you need to do continuous monitoring of the performance of that device. And so even if you were to deploy a model somewhere where the population is just not representative of what had been used initially for training, when you did that monitoring, when you first applied that initial quality control, you would see that, potentially you might see that the performance you're getting is just not representative. And we have a legal and regulatory framework in place to ensure that if that ever happens, it will be picked up and corrected.
So what can artificial intelligence do to enhance the patient experience of screening, diagnosis or treatment?
So in kidney cancer, which is the area I'm interested in and treat, we have been developing a screening approach for people who are at high risk, so people who are smokers or ex-smokers. And in that work, the studies we've undertaken so far have been adding a CT scan of the abdomen, of the tummy, onto the CT scan of the chest that's done in lung cancer screening for that group of people. When we scanned over 4,000 people, we found that just over 5% of people had a serious abnormality in their abdomen, be that a cancer or a new abdominal aortic aneurysm that required treatment or follow-up. So that all sounds great, it's an effective approach, but the problem is that all of those 4,000 scans needed to be reported by a consultant radiologist. So it's a big extra potential burden on the National Health Service. If we can automatically interpret those, then we will reduce the workload substantially.
How does or will artificial intelligence affect shared decision-making?
Shared decision-making, in my view, is essential. So that means not the doctor isn't having a paternalistic approach to the treatment of a patient. It is all options are discussed with everybody, and then they are prioritized based on personal factors of that patient.
Are patients involved in the development of AI tools?
I'm a great believer in patient involvement in all of our research. In fact, my best ideas have actually come from my patients in my Monday morning clinic saying to me things like, whilst I'm waiting for surgery, is there any treatment available? Or you've picked up this kidney lump by chance, why is there no screening program? So patients are critical in forming questions for you to think about addressing. And then when you seek to address those in clinical trials, they're critical for allowing you to work out the best design of a study to do that. So in the same way as we move into artificial intelligence-based research, they are absolutely critical in terms of what is tolerable as the end user of artificial intelligence. So I'm an end user as a doctor, but so are the patients in terms of how they interact with any tools that we develop or decision aids that we use.